Okay, so I think now we are on time. We are here with Professor Tin Aung from Singapore. Thank you, Professor Aung, for accepting our invitation again. And Professor Aung will talk about the asymptomatic primary angle closure suspects and their management. So please go ahead, Professor Aung, and thank you again.
Thank you so much. Welcome to all my friends and colleagues in Colombia, and thank you for giving me an opportunity to give this talk. And I have no disclosures. So I come from Singapore, and this is in the middle of Southeast Asia. So you can see it's very far away from Colombia. I went to Colombia about more than 10 years ago. And then I flew via the United States to get to Colombia. So Singapore is a small island. You can see here in the map, it's a diamond-shaped island. And we are surrounded by Malaysia in the north, and we are connected by 2 bridges to Malaysia, and by Indonesia in the south and in the west. So we're in the middle of the Southeast Asia. And we are only a small country. We only have about 685 kilometers square. And we have about more than 5 million people. So it's a very urbanized and very quite crowded place. And here you can see some photos of the Singapore skyline here. And we're also famous for multicultural food. We have many different cultures living in Singapore. We are about 75% are Chinese, and then we're a mixture of Indians, Malays, Caucasians, and other races. This is my hospital, is a Singapore National Eye Center. We see about 350,000 patients a year, and we do about 15,000 surgeries a year. And I'm the head of the Singapore Eye Research Institute, which is the Research Institute of the Singapore National Eye Center, and we have about 250 staff. We have about more than 25 MD PhDs and about 45 PhD scientists. And I'm the Deputy Medical Director and the head of the SERI. And actually, next year, I'll be taking over as the Director of the SNEC. I'll be the new chair. So my interest is on angle closure glaucoma as well as molecular genetics. So let's talk about angle closure glaucoma. So we know it's an important cause of glaucoma, especially in Asia, and it affects more than 20 million people. Now, the prevalence of angle closure glaucoma is about 1 to 2% in many Asian populations. But if you look at these Asian populations, the prevalence of the narrow angles or the angle closure suspects is between 5 to 8%. So just from these numbers, you can tell that most of angle closure suspects will not progress to angle closure glaucoma. And in the past, we didn't have very good estimates about the progression rate. And based on limited studies, we thought the progression was about maybe 30% in 5 years from angle closure suspects to primary angle closure, and another 10 to 20, 30% from primary angle closure to primary angle closure glaucoma. So we thought this was the approximate progression rate. So let's talk about a patient. Let's say a 59-year-old woman comes to your clinic with a hyperopia of +2 diopters, has good vision, 6/6 or 20/20, with shallow anterior chamber, a very minimal cataract, normal intraocular pressures, and normal optic disc and visual fields. But on gonioscopy, you find appositional closure with no synechia, so like 3 quadrants of appositional closure. And here you can see an anterior segment OCT showing iris angle apposition. So this is a patient who is PACS or narrow angles. And of course, she's in your clinic, as you see for the first time. How would you manage this lady? What would you offer her? She's got good vision, minimal cataract, and normal pressures, and no visual field or disc damage. So I think the options are whether you should do a laser PI in both eyes, whether you should offer a pilocarpine, should you offer a bilateral phacoemulsification, or will you just observe her? And I think probably the right answer is either you do a laser iridotomy in both eyes or you observe her. Now, if you say, I will observe her, and you just tell a lady, come back in 1 year, you worry that in that 1 year, she may develop acute angle closure, and this can be blinding, or she may come back 1 year later with chronic angle closure glaucoma, and you worry about being sued because you did not ask her to do a laser iridotomy. So this is what we worry about when we see a patient like that. And we know that laser iridotomy is effective in pupil block because it relieves the pupil block element. And you can see in this example, a patient with angle closure before iridotomy, and the angle opens up after iridotomy. So we also know that many people do a prophylactic laser iridotomy for PACS to prevent progression, prevent an acute attack. And so this is commonly performed. But you also remember that there are also some adverse outcomes of laser iridotomy. Particularly, patients may have visual disturbances. Sometimes you may damage the cornea, and sometimes you may cause cataract progression. So the question is, how should you counsel patients who are PACS regarding laser iridotomy? What are the risks versus the benefit of doing an iridotomy? And what is the risk of progression if you do nothing versus if you do an iridotomy? And of course, we also don't know who are at most risk for progression from PACS to PAC and PCG. That is a golden question, because if you know who are the ones at risk, then you can treat them rather than treating everybody. We know that the burden of treating all PACS with iridotomy is high. Remember, 5 to 8% of Chinese people above the age of 50 years have narrow angles. So this translates to millions of people in China, for example. And of course, in a country like China, where there's a high rate of angle closure, the question was whether we should screen for angle closure and offer an iridotomy. So we will describe to you today 2 trials. And actually, the 2 trials were designed by my group. And except that, we started about the same time. And the one trial was in China called the Zhongshan Angle Closure Prevention Trial, or the ZAP trial, because ZAP stands for Zhongshan Angle and Prevention, so ZAP trial. And the Singapore trial was called the Analyst trial, or the Asymptomatic Narrow Angles Laser Iridotomy trial. So they were 2 sister trials which had the same protocol, and we had almost the same protocol, except the China trial was slightly bigger because, of course, as you know, China is a much larger country than Singapore. But the ZAP trial was published first in 2019. And this is because the country, China, is very organized, and they could recruit so many patients in a very quick time. So in less than 1 year, they managed to complete all the recruitment and follow up all the patients. Whereas in Singapore, we took almost 4 years to complete recruitment. So that's why we started about the same time, but we ended much behind the ZAP trial. So both questions were designed to answer the question, how should we manage asymptomatic narrow angles, or PACS? And let's start with the ZAP trial. It was a randomized controlled trial. We recruited patients with bilateral narrow angles above the age of 50, and they were randomized. One eye did iridotomy, and the other eye had no treatment. So this was a randomized controlled trial with an intra-person comparison. And they were followed up for the ZAP trial. They were followed up for 6 years, and they recruited about 900 patients. Remember, I told you, they recruited very quickly, 900 patients in less than 1 year. And everybody underwent laser in one eye and no treatment in the other eye. And the primary outcome was the incidence of primary angle closure, or PAC, which was defined as IOP above 24 on 2 separate occasions, or 1 clock hour of PAS, or acute angle closure. So any of these were the endpoint. And the secondary endpoint was looking at the progression of the pressure as well as the optic nerve and other events. So the ZEP trial, the mean age of participants was 59 years and 80% were female. Most of the iridotomies were done superiorly in the iris, either in the rest temporal or nasal. And this was dependent on the crypt position or easy to do crypts. And about 75% completed the follow-up in both arms. Now, the overall incidence of the endpoint was 4.19 per 1,000 eye years in the iridotomy eyes versus 7.97 per 1,000 eye years in the control or observation arm. So this is almost double. And of course, this was highly significant. And in 10 patients, the outcome occurred in both eyes. So in raw numbers, this is actually about 2% progression in the iridotomy group versus 4% progression in the observation group. So you can see it's about double. But overall, you could see that the progression rate was very low. 2% versus 4% is overall very low. And this was over 6 years. And this was only to primary angle closure, not to primary angle closure glaucoma. And the risk factor for progression in the ZEP trial was narrower angle width at baseline. And this was the main risk factor. So this was a very surprising finding because the rate of progression was much less than we expected. As I told you, we thought maybe 30% would progress, when only about less than 1% per year progressed. Okay, and this was in the eye which was observed, 4% progressed. And of course, if you did the iridotomy, you reduce the risk by half, or the other way of looking at it, of course, if you don't do anything, your risk increased by twice. And iridotomy was found to be safe with no long-term adverse events. And remember, the majority of them developed, the endpoint was PAC, and most of them was development of PAS, and very few of them developed high IOP or acute angle closure. I think the ZEP trial had about 7 or 8 cases of acute angle closure. And of course, as you know, PAC itself is not visually disturbing. So the ZEP trial recommendation was that patients with PACS should be told that the risk of angle closure glaucoma is actually quite low just by observation only. Of course, acute angle closure can occur in the rare cases, and particularly if you have regular pupil dilation, you can result in acute angle closure. And there were 2 or 3 cases where the angle closure was the result of pupil dilation during follow-up. And so there's an option of observation with no LPI. And definitely in terms of China, of a community-wide strategy, they do not recommend community-based screening to identify PACS followed by a prophylactic laser PI. They don't recommend it on a national or community level. Of course, you would say the ZEP trial are Chinese people, but remember, Chinese people actually have higher risk of progression. So if you extrapolate to Caucasian people, for example, we think that the risk will be even lower. Another issue was that these were slightly younger people. They were 59 years. But this was intentional. We wanted to recruit people who had minimal cataract. And because this was the question, should we do an iridotomy? Those who have older, who have cataract, you don't need to answer this question because you can just take out the cataract. And of course, ZEP trial, they recruited patients from a community setting in China. And so this is perhaps a different recruitment strategy, and I'll talk to you about Singapore later. Before you go on, let me just show you a very spectacular swimming pool in Singapore. You can see this building on the top here. And on top of this huge building, there's a very gigantic swimming pool, which is like more than 150 meters long. And it's a very famous infinity pool. You can see here on the bottom right of my daughter. It looks like I'm going to throw my daughter over the 60th floor of the swimming pool. But actually, there's something behind. Yeah, so it's a famous swimming pool in Singapore. If you ever visit Singapore, you should come and visit and stay in this hotel. Okay, so let's move on now to the Singapore trial called the Analyst trial, or the Asymptomatic Narrow Angles Laser Iridotomy trial. So this is what the trial was called. Some of my colleagues make fun of me and said it's the anal trial. So it's not the anal trial, it's the Analyst trial. And again, the protocol was the same. You have patients who were randomized, one eye to iridotomy and one eye to follow up. And we followed the patients for 5 years. And this was a smaller study. We recruited
Por favor, apaguemos los micrófonos. Excuse me, Dr. Aung.
It's okay. 480 patients in this trial. So it's a smaller trial. And in this ZEP trial, in this trial, we had again more women than men, and most were Chinese, with the mean age slightly older, 62 years compared to the ZEP trial. And you can see here on the top right, we took so long to recruit because many patients declined to take part and many were excluded for various reasons. But finally, we recruited these patients and it took almost 3.5 years to recruit them. So here are the baseline characteristics of the patients. They were similar in both the iridotomy and the control group. And overall, you could see that these were people who had quite a lot of angle closure, and some of them 90%, more than 95% at 4 quadrants of closure. So these were not mild cases of PACS. Okay, look at the outcomes. And remember, the ZEP trial was 2% versus 4%. And here we had double, almost, more than double. We had 5% progression in the LPI group versus 9.4% in the control group. So it's almost, again, almost double or half the risk if you do an iridotomy. And here, if you look at the per 1,000 eye years, was 11.65 versus 21.84 per 1,000 eye years. So the number needed to treat was 22, and the population attributable risk was 38% for PAC and 50% for PACG. And you can see here the Kaplan-Meier, it shows you gradually as you go longer and longer, you get more and more progression. And risk factors for progression for our trial was age as well as baseline IOP. In terms of safety, again, we had very good safety outcomes. There was no difference in endothelial cell count or IOP spikes overall. And so our study was maybe double or slightly more than double the progression rate of ZAP, okay, 9.4% versus 5%. So again, if you do the iridotomy, you reduce the risk by more than half, or if you don't do anything, you increase the risk. And those who progressed mostly developed PAC. There are only 3 people who had acute angle closure attack. So again, our results were consistent with the ZAP trial findings in the sense that we found that LPI was overall a safe and prophylactic treatment. But I would say overall, the effect was quite not as good as we expected, okay? And the overall incidence, as I said, was low of only at 5 years, okay? So this was quite consistent with the ZAP trial findings. So if you compare the 2 trials here, you can see the numbers in grossly. So untreated, you can see 4 versus 2 in Singapore, 9 versus 5 compared to China. So why the difference between Singapore and China? I think in Singapore, we recruited all our patients in a hospital-based setting. So these were people who were already in the hospital setting. Secondly, the slightly wider angle width at baseline in the ZAP trial. We had more, slightly worse angle closure. So maybe a more advanced stage of PACS. And of course, there are some racial differences. China and Singapore are slightly different. Although we are also majority Chinese in Singapore, we are a little bit different in the genetic profile. So the question remains, has these 2 trials affected management of PACS? So I think in our system, I mean, what we conclude is it provides very good evidence that shows the low risk of progression for PACS. And remember, in both trials, the endpoint was PAC and not PACG. So PAC by itself is not blinding. Of course, if you leave it for a long time, it could lead to PACG. And it raises the question of whether we are over-treating PACS when we do LPI for everybody. And as I said earlier, certainly on a population level or a community level, we will not recommend doing a prophylactic LPI on a large national scale. But of course, at the clinic level is different. And this is where you need to discuss with your patient on the individual level. And of course, finally, you have to consider whether this data applies to countries like yours in Colombia, where you have different rates of angle closure. So how do I manage my PACS patients now? So if I have a patient with PACS, I will tell the patient what they have, that they have narrow angles. They are at risk of getting angle closure, glaucoma, as well as acute angle closure, and give them the options, observation versus laser iridotomy. And I quote the data from China and from Singapore. So I tell them, maybe 10% will progress if you do nothing versus 5%. And so you reduce the risk by half, and explain the risk of both options, and I let the patient decide what he wants to do. Some patients understand the concept of risk, and they say, okay, I understand. I prefer to do an iridotomy because I don't want to get angle closure glaucoma and I want to reduce my risk. Others say, yes, I understand. I want to just observe, and I understand that I'll have some risk, but the risk is low and I'll come back once a year. So this is quite a good conversation with your patient if they understand, of course. But in some patients, they don't know, or they say, I don't really understand. Can you decide for me? Or they are in doubt. And usually in such cases, I would offer the iridotomy because these patients don't understand the risk, the concept of risk. Okay? So they think it's an all or nothing kind of a option. And so those patients who don't understand risk, are just let's do the iridotomy, to be safe. Okay. And as I said earlier in my talk, those who are older, who have cataract, just offer them a phacoemulsification because you don't need to offer iridotomy or observation. You just have to take out the cataract, and this will, of course, also remove the risk of angle closure attack, acute attack, and pupil block by removing the lens component. So older patients just offer a phaco. As you know, the lens plays a major role in angle closure, and this is if you remove the lens, you will of course remove the pupil block element. And look at this patient with a very large lens. We call this a large lens vault. You can see that the lens is very large, especially jutting into the anterior segment. It looks like almost like a mountain or a volcano. And in this kind of case, there's no point offering a laser iridotomy. You just have to take out the lens. So in these cases, it's obviously clear. You just take out the lens. And here you can see some examples of patients who had laser phacoemulsification. And after the phaco, you can see how the angle opened up and the patient's pupil block was relieved. So who should go for laser iridotomy? Definitely patients who have PAC, PACG, or acute angle closure, and fellow eyes of all these people should go for iridotomy. So this is clear. So amongst those who have PACS, I would definitely recommend iridotomy for people who are symptomatic. That means they may have intermittent headaches or pain from the eye, and they may describe to you intermittent angle closure, which could be a precursor to an acute attack. And so these are people who definitely you should do an iridotomy. People who need regular pupil dilation, for example, people who are diabetic or those who have retinal pathology and need to examine the retina regularly, and they have PACS, you should do the iridotomy. A third group are people who have poor access or follow-up, and perhaps they live in a rural setting. And of course, in those people, perhaps you can offer the iridotomy because If they get an acute attack, it may be many hours or days before they come to the hospital. Of course, in Singapore, where we have many hospitals and clinics, is not necessary because people can come, anytime they can reach a clinic within 10 to 20 minutes. Yeah. The fourth group are people with family history of ankylosing glaucoma. So this is a question mark, but I would definitely recommend it for people tell you that their mother or their brother has very bad ankylosing glaucoma, had surgery, went blind, etc. Why not do the iridotomy so that they don't have the same risk in the family? Finally, population of patient specific, we don't know. Some populations may have different factors which put them at risk of progression. So I know in Colombia, for example, you have some indigenous people who have a high rate of ankylosing, and perhaps those people, may need an iridotomy, perhaps compared to those who are Caucasian background or African background. Okay, so in summary, I presented to you 2 trials conducted in Asia, one in China, the ZAP trial, and the second trial in Singapore, the Analyst trial, which had the same study design. They recruited patients with PACS in both eyes, randomized to 1 eye iridotomy and 1 eye observation. And they found overall the risk of progression was very low over 5 to 6 years. In the ZAP trial, it was 4% in the untreated group versus 2% in the laser group. In the Singapore group, it was 9.5% versus 5%. So it's much lower, slightly higher in the Singapore trial, but overall still a low risk. So this provides good evidence that there is an option of observation for patients who have PACS versus iridotomy. And of course, as I said earlier, you should discuss the risk with your patient and then come to a decision together. If in doubt, or the patient doesn't understand the risk, I would advise you to do the laser iridotomy. And in older people with cataract, just remove the cataract with the phacoemulsification, and you don't have to worry about this question. So I'd like to acknowledge here all my fellows who have worked with me over the years, and my collaborators from China, Ming Guang He, David Friedman from the US, and Paul Foster from the UK, and my other collaborators from Singapore and from my hospital, and also my glaucoma research team in Singapore, and funding that I have from the National Medical Research Council in Singapore, the National Research Foundation, as well as the Kwan Im Tong Hu Cho Temple. Thank you for your attention.
Professor Aung, thanks a lot for your very interesting conference, and no doubt that we learned a lot from your studies and experience. Now I would like to ask the attendants if is there any questions or comments?
Buenos días.
Buenos días.
Soy Alfonso Mendoza desde Cali, Colombia, y quiero preguntarle al doctor qué relevancia le da a la gonioscopia en el consultorio, gonioscopia dinámica, comparado con el VM, hacerle VM al paciente y el resultado del VM.
O OCT, también le preguntamos.
OCT. Vale.
Dr. Mendoza from Cali, he's asking Professor Aung, what do you consider the importance of the gonioscopy, the dynamic gonioscopy against the UVM, ultrasonic biomicroscopy, or OCT of the angles?
Yes. So clinically, we use gonioscopy to diagnose angle closure, and that's because gonioscopy is a more dynamic process. You can differentiate between appositional closure versus synechial closure. You can look for areas of synechial well, and you can get a good visualization of the angle in 360 degrees. We also use imaging, and particularly we use anterior segment OCT. For the ZEP trial and the ENDLISH trial, we did not have imaging for everybody, but we had quite a substantial number had anterior segment OCT. And nowadays, there is even a 360-degree OCT by swept source, okay, which is almost like a gonioscopy. You can get a 360 view of the angle. And this is like a nice way of looking at the angles. UBM also we do sometimes, particularly for patients with plateau iris, but we don't do UBM routinely because it's a little more difficult to do, and you need a good technician. Yeah, but we agree that we do imaging as well, but we use gonioscopy, clinical gonioscopy as the main method to diagnose ankle. You don't need to have imaging if you don't have it. Yeah, so if you have imaging, it's nice to have it, to document it, and to show to the patient they understand what we're talking about when you show them the OCT. And it's good for documentation as well as to documenting changes of the angle over time. Thank you.
Professor Aung. And I have a question. I remember a couple of cases many years ago with very, very narrow angles that when dilating those patients for performing the phacoemulsification, they had an acute increase of the intraocular pressure. They had an acute glaucoma attack before beginning the phaco, and finally the surgery was not possible because the eye was too high pressure. Have you had such cases, and what are your recommendations? Yeah. Because we began to perform in very narrow angles preoperative iridotomy to try to avoid this intraoperative complication.
I think it's pretty rare. I mean, I probably had 1 or 2 cases in my lifetime, because I don't know, maybe I'm lucky, but usually, if they have cataract with narrow angles, we just tell them to do this cataract. We don't do a perfect iridotomy. But if they have an acute attack on the table, we will give them mannitol, and then we just carry on with the phaco, because removing the lens will solve the problem. Yeah. And if their cornea is very hazy, we will scrape off the epithelium and just do the phaco. Yeah. Because they will solve your problem, you know what I mean? Yeah. Yeah. Of course, if that usually if the attack it just happens on the morning or just during the dilation, it's quite, you can do it, you just give mannitol and you just carry on. It's not that bad usually. Yeah. Yeah. The worst case scenario, I've had one patient, one of my colleagues, they called in a retinal surgeon and they did a 23 gauge vitrectomy of the anterior vitreous, and then they carry on the phaco. Yeah.
Perfect.
Yeah.
Okay. Is there?
There's a hand up by Dr. Gustavo.
Yeah, Dr. Aung, how are you? My name is Gustavo Espinosa. I'm a glaucoma specialist from the institution. I want to ask you, I have 2 questions. In the case of those patients that have PACS and we decide the observation, how often would you recommend the follow-up visits?
That's a good question. I just see them once a year, but I tell them that if they get like a acute attack symptoms, they come back anytime. Yeah, but I usually see them once a year.
Okay, and another question will be, we know that gonioscopy is highly dependent on the evaluator, and well, most of the cases we see in our clinical practice that other general ophthalmologists don't do gonioscopy, but rather go with the Van Herrick estimation. So would you recommend or would you think that Van Herrick, based on your study that the angle width, I believe that with the Van Herrick estimation shows that the patient could have higher risk factor for PAC or PACG?
No, we looked at Van Herrick. It was not found to be predictive. It wasn't. We didn't find. But Van Herrick is useful to pick up like a screening for people with narrow angles. And then, of course, they should confirm it with the gonioscopy. So for your colleagues, who pick up these patients with cataract, they should refer them to you or to do gonioscopy and to confirm it. Yeah, but it's a useful screening test, but it was not predictive of progression.
Okay, thank you very much.
Thank you.
Professor Aung, and Dr. Espinosa has been working with the CASIA-2 to try to solve the problem that he is talking about. Okay, many of us who are not glaucomatologists are not really expert in gonioscopy, so maybe in a refractive clinic or in another setting without a glaucomatologist and with an OCT like the CASIA-2, it has a software that can check 360 degrees of the angle, so could be a good screening tool, maybe. What do you think?
Yes, I agree. I think it's useful. Yeah, except that the CASIA is quite expensive equipment, so it's not going to be widely used. It's only have in certain select centers. They have, you can buy such equipment which is expensive. Yeah, so I think gonioscopy is still a cheaper way of doing assessment. Yeah, but certainly if you have the CASIA, it's great to use it because it is a way of imaging the angle in 360 degrees. Yeah, in fact, we published quite a lot of papers on the CASIA, and we have now got an automated software which can grade 256 angles of the CASIA scan and then summarize each of the angles. So we published this recently in British Journal of Ophthalmology. So basically what we do is that, if you take a 360-degree CASIA scan, it takes 128 cuts around the angle. So 128 cuts actually shows 256 angle images, right? And what the software does is that in each of the angles, it grades it automatically using machine learning, open or closed. And then finally, you summarize the 256 angle cuts. And let's say if half of them are closed, then you get a number 180 degrees of closure. So this is like an automated way of grading the CASIA images. Because right now, the software is not that easy to use. You have to manually mark out some of the scleral spur, etc. So our concept is that you should do it with the software. They can automatically grade the angles so that the ophthalmologists don't need to do any kind of grading. Yeah. So that's our concept. And recently we published this concept in the BJO, and we even told Tomei, this is a nice software. Why don't you use it on your device? And it's automatic grading of the angle images for the doctor to use. But they said that it was they had to do some regulatory process, and it's too difficult for them, so they didn't want to use our software. They use their own software. But I think that the future is that if we have an imaging device that can get multiple cuts of the angle, combined with a software algorithm which can automatically grade the angle using machine learning, you can get an automated assessment of the angle, just like you do it as an automated gonioscopy. Yeah. But this is we think is a concept.
Professor Aung, thank you. Very interesting. I think that Dr. Espinosa will be very, very interested on that software. Okay, are there any other questions?
Can I ask your Dr. Tello and your colleagues, do you see a lot of angle closure in Colombia?
Yes, please, maybe Dr. Espinosa or Dr. Parra can ask, because I am a cornea and refractive surgery specialist, but they are the glaucomatologists. Okay, go ahead, Dr. Espinosa or Dr. Parra, please.
So Dr. Aung, in my case, I don't see them too much because my practice is not in the emergency. So what I see is patients from the casual consultation, but I believe that our other colleague from as a glaucoma specialist, Dr. Parra, he sees a lot of acute angle closure. I don't know if he can talk about his experience.
Yeah. Hi, Dr. Aung. I'm Juan Camilo Parra from Bucaramanga also.
Hello.
Yes, we see often, but I'm agree with you. I think that the problem here is that we don't have the easy access to the ophthalmologist, and that's the way we have so much acute glaucoma or close angle glaucoma. I think at this moment, the worst indicated surgery in the eye is making the prophylactic iridotomy, because it's most of the general glaucoma ophthalmologists don't make the gonioscopy. I'm really agree with you, but we see often, really often, not as full as they think, but it's really often. We have a whole bunch of narrow angle because we have Afro-American people here, and that's why that we can see a lot of them. And
What
also
people?
when we African-American people.
African-American. Oh, okay.
Yeah, so that's why we have a lot of narrow angles here. Maybe there is La Doctora Araujo in Cali that also can speak about that.
I was told that in Colombia you have this indigenous people. They are like Asian origin. Is that true or not?
Yeah. No, we don't have so much Asian people here.
Excuse me.
Not so much.
Go ahead, Dr. Araujo.
Oh, my name is Carmen Diaz. I am from the north
He was
coast
here,
of
but
Colombia.
now it's not.
Please,
Okay,
Dr.
I
Dr.
am
Diaz.
from the north coast of Colombia.
Yeah.
Yes, we have a lot of people who are indigenous, you know, and we have find a lot of angle, closed angles, and the problem we're having is just that Dr. Parra said that we have difficulties to get to those people and to do iridotomies. So the system doesn't let us help them a lot. But we have a lot of people here in the Caribbean, and also we have Afro-Americans.
Okay.
We have lots of glaucoma, both
Yes.
types.
Because you know,
the issue is that Colombia is a large city, and we have many different regions, and in some there are an important percentage of indigenous population also, but in others we have not really a significant percentage of indigenous population. So there may be some differences between different regions.
Because I work with Dr. Perez Grossman from Peru, and he also has lots of agriculture among the indigenous people in Peru.
Yeah, I know him. There is a lot of people in Peru who has angle kosher. They have really a huge amount of indigenous there.
Correct. Okay, very interesting.
Professor Aung, thank you again.
Dr. Tello, I have one last question for Dr. Aung.
Go ahead.
Dr. Aung, in the case of patients that have PACS, primary closure suspect, and they have like this configuration like a volcano that you said, do you have a cutoff point? Like in the case we have a clear lens, do you have a cutoff point, let's say, of lens volt parameter to say, oh, well, we can observe this patient, or maybe I recommend phaco for this patient?
Okay, that's a very good question. And we have looked at this data. We have population, data on the lens vault. So in our population, we know, I think the cutoff is around 350 microns, I mean, where it is like more than the 75th percentile, okay? But we don't have data on, you know, at what percentile results in a better outcome. We don't know. We just know the spread in the population or the distribution, but we don't know what figure you should be doing the surgery. So it's very subjective. We just look and say, look, this lens is like a huge lens vault. Just take it out. You know what I mean? You know, and I agree with you, it's difficult, but for those cases, especially with a good vision, with a big lens vault, you have to document it with the anterior segment OCD because, you know, you're doing surgery in people with relatively good vision. Yeah, but you're doing here not for cosmetic reasons, but because of anatomical reasons. Yeah, so it's different. Not like you're doing a clear lens because these are people who have no cataract. These are people with significant anatomical problems. Yeah.
Professor Aung, thank you again for your kindness and for sharing with us your knowledge. And have a very good night for you in Singapore.
Thank you very much. Thank you.
And
have a good day.
And thank you everyone for being with us.
Thank you. Bye-bye.
Bye.
Thank you.
Bye. Thank you very much.
Bye bye.
Bye.